Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips, and Practical Tips. Today, I'm going to share with you an interesting case of a solitary fibrous tumor arising in the spine, which is really a rare occurrence since solitary fibrous tumors, or what has been previously known as hemangiopericytoma, usually arises supra-tentorially. So this presentation is quite unusual. This is a 28-year-old male patient who presented with back pain and was found to have a dura-based mass on T11, T12. And this is the squash prep of the tissue at the time of frozen section. And as you can see, this is a cellular tumor, and there is a proliferation of this oval shaped cells with tendency sometimes at spindling, that with the minimal pleomorphism, not much in the way of mitosis or necrosis, and some eosinophilic a granular material in the background. Now, I don't know if you will be able to see this one, but this nuclear contained intranuclear inclusion. And the thought at that time was that probably this can represent meningioma. Now, other sections, however, showed this, other areas, however, showed this really high vascularity with the blood vessels traveling in all directions, reminiscent of transection roads, highways, actually. And this should bring into the differential diagnosis vascular tumors, something like the solitary fibrous tumor or hemangiopericytoma. And please pay attention to this very peculiar appearance or shape of the vessel. This is the staghorn vessels that we tend to see on sections under the microscope. So the section of the frozen section actually contained this area with fibrous tissue or fibrous plaque. So if we put it all together, despite of the unusual location, solitary fibrous tumor / hemangiopericytoma would come into the differential diagnosis, and the permanent sections actually showed these areas which are hypocellular areas with a large amount of this colloid-like fibrous tissue, similar to the ones that we've seen at the time of the frozen section. And the cells are oval to spindle shape with no really discernible mitosis or necrosis. Now, other areas were much more cellular, but the same appearance or characteristic features of the cells. And actually, this material, pink material in the background, is what we have seen on the smears of the frozen section. And the characteristic feature, the staghorn vessels. Once you see this, really, it's like a giveaway diagnosis. This is really in that location, in the spinal cord or in the central nervous system. A lesion that is dura-based with this appearance of the vessels would be consistent with solitary fibrous tumor. And just to bring back this interesting vessel that we've seen at the time of the frozen section on the squash preparation, exactly similar to depicting exactly the staghorn appearance of the vessels that we see under the microscope in the section. There was only one single mitotic figure per 10 high power fields, and this is important because the grading of solitary fibrous tumor depends on the number of mitotic activity or mitotic figures, as well as the presence or absence of necrosis. And in this case, mitosis was scarce, less than 2 per 10 high power fields. There was no evidence of necrosis, so the grade of this tumor would be consistent with a grade 1. Now, in order to confirm the diagnosis, we stained the tumor with the STAT6, and STAT6 is a strongly diffusely positive nuclear stain in the tumor. Now, remember, in order to ensure that my immunostain is working properly, I have to have internal negative control in this case, because normally there shouldn't be any tissue that would stain with STAT6. So in the normal endothelium, for example, would be completely negative, while the tumor would contain the STAT6 staining, which corresponds to the mutation. Now, previously, before the era of STAT6, we used to depend on other immunohistochemical stains, one of which was CD34. And CD34 tends to stain the vessels, the normal vessels, and this is another staghorn vessel, but also the tumor cells. And there is some granular membranous to cytoplasmic staining in the tumor cells, which would be interpreted as positive staining. BCL2 was also beautifully positive in the tumor cells, and this is one of the stains that we used to use also for previously to support the diagnosis of solitary fibrous tumor. Now, excuse me. Remember that BCL2 stain is cytoplasmic, while, for example, the BCL6 stain is a nuclear stain. So for BCL2, I should be looking for cytoplasmic staining. Now, also reticulin special stain used to be performed previously, and what we be looking for is the presence of small groups of cells or individual tumor cells invested within the reticulin fibers. And I always perform Ki-67. It helps me actually to look for hotspots or areas of increased mitotic activity. And I almost always do it and then find this area, map this area on the Ki-67, and then on the corresponding H&E slide, and I would go and count mitoses in the hotspot. And this is extremely important in any central nervous system tumor, because sometimes it's difficult really if you have like 4 or 5 slides just to go and look for mitotic activity. So one way to help you find the areas with the highest proliferative activity is to perform Ki-67, and Ki-67 was interpreted as 3 or 4%. So the final diagnosis was consistent with solitary fibrous tumor, CNS WHO grade 1. I hope you find this tip useful in your daily practice. Thank you.